Let's talk about blood urea nitrogen. BUN. Blood urea nitrogen. Blood urea nitrogen is found in the Chem 7. If we look at our fishbone here. And its normal range is in and around 10 to 20. Blood urea nitrogen is made from nitrogen, made in the liver, and it is excreted, or I should say filtered, and reabsorbed in the kidney. There are many factors that cause an increase in BUN. Those factors include catabolism, for which there is a steroid-dependent transcription factor, gastrointestinal bleeding, which is essentially digestion of nitrogen from the blood, a decrease in the glomerular filtration rate, so decrease in kidney function, pre-renal, azotemia, another factor is nitrogen intake, and that may be through food, through tube feeds, or through total parenteral nutrition. So BUN itself is not a very good marker for kidney function. As you can see, there are many factors involved in the increase in BUN. I commonly see patients with BUN creatinine ratios that may be 50 to 1. These particular patients have a high BUN for many factors and many reasons, likely unrelated to the kidney function. Occasionally, these same patients will have BUN creatinine ratios that increase to 150 to 1 over a period of 3 days. These particular patients are patients who have, in the interim, added TPN, steroids, and are catabolic. at baseline. Let's talk briefly about prerenal. Azotemia. If we have a patient who has no access to water or salt in a relatively hot environment, that particular patient is going to conserve water, and retain salt. This happens in the proximal tubule and is not specific. At the same time, when we're conserving water and retaining sodium, BUN is passively reabsorbed in the proximal tubule. And so an increase in BUN from, let's say, 12 to 1 ratio of BUN to creatinine to 25 to 1 is indicative of a patient who is passively reabsorbing BUN in the face of relative decrease in renal perfusion. In prerenal azotemia, the BUN goes up because of passive reabsorption in the proximal tubule. Let's think of another example. Let's think of a patient with end-stage liver disease. This particular patient doesn't make much BUN. Remember, BUN is made in the liver. And so in patients with end-stage liver disease who happen to have acute kidney injury, those particular patients will not have very high BUNs. Let's look at a scenario. A patient with end-stage liver disease and acute kidney injury patient with end-stage liver disease and acute kidney injury will probably have a BUN peak of 20 compared to a patient with acute kidney injury without end-stage liver disease. We may expect that BUN to be 60. So in patients with end-stage liver disease, BUN production is poor. And so even in the face of a decreased glomerular filtration rate, GFR, a patient with end-stage liver disease will have a relatively low BUN produced compared to a patient who doesn't have end-stage liver disease.